Welcome to week 4. This week we're going to talk a little bit about pharmacokinetics and pharmacogenetics. And just a quick review here, pharmacokinetics means the absorption, bioavailability, distribution, metabolism, and excretion of a medication. And really when we're talking about drug-to-drug interactions with cannabis, this is an area where we definitely still need quite a bit of research. A lot of times what you're going to hear me talk about throughout the course and even in this little module right here is how often people make assumptions about the way that other medications are metabolized and try to apply that to cannabis, and it's not always apples to apples. We know that absorption, so the route of administration determines cannabinoid absorption and bioavailability. We know that the route can also impact whether drug interactions occur, with interactions more common when both drugs are taken orally and then subsequently processed through the liver. So we hear this a lot with polypharmacy, right? You can take one drug, maybe have a 10% chance of having an adverse effect or a side effect. You take 2, it goes up to 20%. By the time you get to 10 medications, it's 100% chance that you're going to have a side effect. And for those of us that are nurses, often we make a joke. And people are taking one medication to help with the side effect of another. And then just often you can see people taking anywhere from 5 to 10 medications is not that uncommon these days. So really looking at cannabis to try to help people manage their side effects and their symptoms can decrease the number of medications they need in general because often there's less side effects with cannabis. We know that inhaled cannabis enters the body through passive diffusion into the capillaries. That's what allows it to work so quickly. People get that immediate effect in about 5 minutes. It doesn't last very long, but it works very quickly. And this, of course, bypasses the liver. So this is the route that people can use if they're very concerned about a potential drug-to-drug interaction. Although I will say, excuse me, I have seen some drug-to-drug interactions with inhaled cannabis and warfarin, which we'll talk about. And then we know we have oral mucosal administration, which can provide rapid relief. But as I've mentioned in some of the previous modules and in class, there are very few products out there that are true oral mucosal products. This is a good example of where tinctures, for example, have been marketed in the cannabis industry to have rapid absorption, 15 to 30 minutes. Most of the tinctures on the market, at least here in California, are oil-based. By definition, a tincture should be in an alcohol or glycerin base. That's where we've been able to demonstrate by holding it under the tongue, it'll have a 15 to 30 minute absorption rate. Oils do not absorb rapidly underneath the tongue, and cannabinoids in their natural state are fat soluble, so they don't absorb well into the mucosa. So you have cannabinoids mixed with oils. When they're put underneath the tongue, they're not going to absorb rapidly, and they often follow the pattern of ingestion, meaning it can take 1 to 2 hours for these to take effect. It's very challenging to help get the cannabis community and manufacturers to get on the same page around this. It often leads to a false sense of product onset. So for example, I shared the story in the webinar about the ladies that went to the dispensary and were given tincture in their drinks and said it'll work in 15 minutes and last an hour. Well, nothing happened until several hours later when they had left the dispensary and now were in their cars ready to drive home. Many of them started to feel the effects of THC and were too impaired to drive. So it's really important that we set expectations. I always say I'm not saying that these products cannot work in 15 to 30 minutes. I think the responsible thing to do is to prepare patients that they may not work for several hours and not to repeat their dose after 15 to 30 minutes. I often don't even let people repeat their dose for 3 days. I want them to really observe and understand how that product is affecting them in terms of onset and duration before we make another increase. We know that cannabis can enter the body through the gut by ingestion as well. And again, as I said, I think a lot of those oral mucosal products are absorbing in through the gut. Before I get here, let me just back up 1 second here. There are some products on the market, though, that have been made to be more water soluble and can absorb underneath the tongue like a sublingual. So, you know, if you do your research, at least here in California, there's a company where their background was in pharmaceuticals prior to cannabis, and they have learned how to make a water soluble cannabinoid product. Now, of course, that can disrupt some of the natural benefits of the plant, and it is often an isolate that they're using to add into the other ingredients to make it more water soluble. We also know that cannabis can enter the body with the assistance of a transdermal agent, and this is another example of where we definitely have good research on how transdermal agents can work, but we really haven't studied it enough in cannabis to understand it. What we know today is that often these transdermal products will include a chemical agent, and that allows the cannabinoids to diffuse across the aqueous layers of the skin. We have some research to demonstrate that CBD can permeate the skin up to 10 times more effectively than THC, Delta 9, and Delta 8, because CBD in general is less lipophilic than THC. So often when someone wants to use a product transdermally or topically, something that's higher in CBD may be more effective. I've actually found that the acidic, so THCA and CBDA, can be really helpful for topical relief as well, because we know that the acidics are less lipophilic than the neutral forms, THC and CBD. We also know that we have CB1 agonist, that CB1 agonists can help with redness and inflammation in atopic dermatitis, contact dermatitis, and psoriasis. So using a cannabis topical may help reduce some of the inflammation with those skin conditions. It can also help reduce arthritic pain and inflammation without side effects. Of course, the deeper the arthritic pain, the harder it will be to treat with a topical. So often I will get some patients who want to use a topical for deep arthritic pain in the hip or the knee. And often those methods may be ineffective, especially if they are obese or have a lot of fat around those areas. Again, you know, the topicals are not going to penetrate all the way into the bloodstream. If there's a lot of muscle tightness and tension in those areas, a topical may be effective, but the deeper the pain, the less likely a topical is to help. People like to start with topicals because, again, they really don't have any side effects, as they often don't reach the bloodstream. And they're portable, they're easy to use, they don't cause any impairment. So when they work, they're wonderful, but it's usually they either work or they don't work. And we do have rectal administration, believe it or not. This is a common method used for people who are trying to avoid impairment. There's also a large community out there on the internet that promotes using rectal administration of cannabis to treat chronic illnesses such as cancer or other serious diseases like lupus or rheumatoid arthritis. The reason it's promoted to use this method is that because the level of impairment is much less than if it was if you took it orally. The reason that this is less likely to cause the impairment is the absorption rate is much lower. So we do have another challenge out there on the internet where people misinterpreted some studies back in the 90s looking at rectal administration, where the bioavailability was 50 to 70% in dogs and monkeys. Most of that research, there's a couple of research studies, they used hemisuccinant, which is a chemical carrier designed to improve the absorption or bioavailability of the cannabinoids. There are no rectal suppository products on the market that have hemisuccinant in them. It requires a special kind of licensing for pharmacies. They have to work under a special hood because of the chemical of hemisuccinant. Subsequent studies that were done without hemisuccinant showed about a 3 to 13% bioavailability of rectal administration. So often people are trying to use high doses of THC and CBD to cure their cancer or cure their autoimmune disease. And when they take it orally, obviously the side effects can be so intense that they can't take it. So they go to suppositories, which can be very expensive. They can also be problematic in terms of absorption. The way that people tend to administer a suppository is often wrong. You know, people should be laying on their left side. They should stay there for 20 minutes to help with the absorption. And sometimes people can actually put the suppository way up past the point where it does reach that hepatic vein. And then what happens is people will have a very intense psychoactive experience, because sometimes these suppositories can be several hundred milligrams, excuse me, of cannabinoids. I actually had a woman call me for her son, her father, who had lung cancer, and they were trying to get up to 1,000 milligrams of THC a day to try to treat his cancer. And the manufacturer of the products had given her a 500 milligram brownie and a 500 milligram suppository. And unfortunately, this daughter, who had no experience with cannabis or dosing, did give her father the 500 milligram suppository and only half of the brownie at night before bed. And he did get up in the middle of the night very disoriented and confused, and ended up falling and suffered a pathological fracture in his back because of his bone metastases. So, you know, these products are often promoted and are given without any medical supervision. And I'm always concerned about someone who's using rectal administration, who's currently actively undergoing chemotherapy. They are immunocompromised, their platelet levels may be low, so they may be at higher risk for infection, or even, tearing the lining of the rectum and causing them to bleed. I have found rectal administration to be helpful for local issues, topical issues, such as a fissure, a hemorrhoid, and in some cases, even rectal cancer. I've had a few patients who have used suppositories to treat their rectal cancer and have gone no evidence of disease. But these, using this method can produce incomplete, unpredictable, and erratic results. People will come back and tell me often that it's poorly absorbed because they find it, the oil in the toilet after having a bowel movement. When they pass gas, it might smell like cannabis. And they might find it leaking into their underwear or their bed sheets at night when they're sleeping. So really, this is not a method that is commonly used, and for obviously good reasons. The distribution of cannabinoids is affected by our body size and by our disease state. What's really important, I think, to understand is that most cannabinoids are metabolized in the liver, especially through oral ingestion, through the cytochrome P450 enzymes. And this is an example of some of the SIPs where cannabinoids are going to have an effect on metabolism. We know at this point that 1A2 is inhibited by THC and CBD, so this may be clinically relevant. Induction can occur when smoking cannabis and tobacco. So sometimes, THC and CBD are going to cause the levels of other medications to increase, and sometimes they're actually going to cause other levels of medications to decrease. And sometimes, just to complicate it, the medications may either increase or decrease the different levels of cannabinoids. And this is where we don't have a lot of research, and we have to use some clinical judgment to determine whether or not it's safe for them to consume cannabinoids with their other medications, and how that may potentially affect their other medications and the cannabis treatment. We know that 2C9 is inhibited by THC and CBD. We know that the CBD is more clinically relevant, and often it's dose dependent. And I'll talk about that in a second. As I mentioned earlier, warfarin's most affected because of its narrow therapeutic index. And this is through smoking and or ingestion. And often what I see in this particular case with warfarin is that those INR levels are going to fluctuate. So just like anything else with warfarin, consistency is really important. So initially when someone's coming to cannabis, their INR is probably going to fluctuate until they find their therapeutic dose. Once they find that dose of their cannabinoids, their INR levels tend to stabilize. And what I tell patients is that when you begin cannabis and you're on warfarin, you need to let your clinic know that you've started cannabis so that they can account for why your INR levels may fluctuate. And I've never seen anybody have an INR level so high that it's caused me to have to stop their cannabis treatment. We also know with 2C9 that the polymorphism 3 decreases enzyme activity. And this is something I'll talk about in just a second here. With 2C19, large doses of CBD may be a strong inhibitor. So you may see actual levels of other medications go up. And small doses of CBD are likely to be clinically irrelevant. So, you know, when we're looking back at dosages, often where I see some drug-to-drug interactions is around 50 milligrams of CBD a day or higher. And I think other cannabis clinicians would agree with that dose as a dose where we start to see some clinical where it starts to become clinically relevant. The 3A45 is where about 50 to 60% of all medications are metabolized, and it's the most prevalent CYP enzyme in the liver. We also have drug transporters, and these are the proteins that may help drugs move from one side of a membrane to another. And drug transporters impact drug absorption in the intestinal tract and distribution into tissues. P-glycoprotein limits the amount of a drug, such as THC, that reaches the brain. And to protect neurons, drug transporters in the blood-brain barrier pump drugs and toxins back into the blood. We've seen studies that demonstrate that CBD inhibits P-glycoprotein, which can increase the level of some drugs. And we've seen that THC induces B-glycoprotein levels in the blood-brain barrier of mice, which can decrease the levels of some drugs. Now remember, inhibition means you'll see increased levels of that drug, and induction means you'll see decreased levels of that drug. With our enzymes, they're responsible for metabolizing the drugs, which helps the body eliminate the drug through inhibition or induction. And as I just said, enzyme inhibition causes the serum levels of the drugs to go up. Enzyme induction causes the serum levels of the drug to go down. And when taken orally, THC and CBD are absorbed into the GI tract and then highly metabolized in the intestine and liver. What we don't really understand is what happens if we have a diseased liver and how that affects metabolism of cannabinoids. But these CYP450s are a family of enzymes that metabolize drugs. These enzymes chemically modify, detoxify, and remove the drugs from the body. And different factors impact metabolism and bioavailability of that in the liver. THC affects inhibition or induction of CYP3A4. CBD can inhibit the activity of CYP3A4. CYP3A4 inhibitors can increase THC and CBD plasma levels by as much as 80%, and CYP3A4 inhibitors can increase the 11-hydroxy-THC by as much as 350%. Now that's incredibly important to know. This is the example I said about a couple of slides ago, where sometimes the THC and the CBD are inhibiting or inducing the other medications. And sometimes those medications are inhibiting or inducing the cannabinoids. So again, we don't know which specific CYP3A4 medications are inhibiting the 11-hydroxy-THC by as much as 350%. So we have to follow them and look for clinical clues to see if they're actually having some sort of drug-to-drug interaction. And the way that that may present is they take a very, very small dose of THC, say 2 milligrams, and they have an extremely psychoactive experience. I did just recently see this with a patient who is taking delta-8 THC, which we really don't know much about the other cannabinoids like delta-8 or CBDA or THCA or CBG and how they are metabolized and interact with other medications. But he did have a very, very strong reaction to delta-8 THC, which is quite unusual and not something I've seen in most of my other patients who've used that. So my guess is there must be a drug-to-drug interaction going on there that's intensifying the effects for him. We also know that there are some terpenes, for example, beta-caryophyllene and humulene, that can inhibit the CYP3A4 activity. With CYP2C9, it's the most important drug metabolizing enzyme for THC, and this can reveal whether a person is a fast, intermediate, or slow metabolizer. We also know that THC levels can be affected by other medications metabolized through this enzyme. And we know that CBD can decrease or increase the serum levels of other medications metabolized through this enzyme. And this is where, you know, some of you are probably starting to feel a little confused or overwhelmed. You know, there are some options out there for people to get some DNA testing that can give you some more information in terms of how they're going to metabolize medications, including cannabinoids. But honestly, the best thing to do if we're concerned about a drug-to-drug interaction is start them low and slow and monitor them. Don't be afraid to increase their dose because of a drug-to-drug interaction, as long as you're not seeing any clinical signs that they're having an interaction. With CYP2C19, we know that large doses of CBD might strongly decrease activity, and those small doses of CBD are likely clinically irrelevant. Again, it's very rare that I actually have to stop a cannabis treatment because of a drug-to-drug interaction. We can often adjust the dosages of the cannabinoids and or the medications they're on to help decrease those interactions we're seeing. With CYP1A2, it does not metabolize CBD or THC, but it does remain relevant for the endocannabinoid system activity. THC can decrease the activity of this enzyme. CBD can decrease the activity, but likely at a level that is clinically irrelevant. And inhaling both cannabis and tobacco can increase activity. So sometimes I do have patients who still smoke tobacco and use cannabis, and what I see clinically is that often they're not processing cannabinoids well. They often don't feel the effects of THC as strongly as I would expect them to, and they need pretty significant dosages that sometimes can become cost prohibitive, and they'll discontinue the treatment, cannabis treatment. The half-life of THC for infrequent users is about 1.3 days and 5 to 13 days for frequent users. And where this becomes clinically relevant is when people are trying to increase or decrease their dosages or even stop cannabinoid treatment. So what we know today is that complete elimination of cannabinoid metabolites occur over several days throughout a slow rediffusion of cannabinoids from body fat and other tissues. So about 20 to 35% is eliminated in urine, and 65 to 80% is excreted through the feces, and most, about 90%, is excreted within 5 days. That's important for two reasons. When someone's starting their cannabis regimen, you know, often if they're going to do an oral route, they are expecting some pretty dramatic results, right? They may have friends or family members who've used it and who are having great success. But often when we're titrating their dose up, it can take several days to evaluate that one dose. So sometimes it takes several weeks for them to get up to the dose that they're trying to accomplish to relieve their symptoms. So it has to build up and accumulate before we see the best benefits. When they're stopping the cannabis, sometimes people will have been on cannabis for several months or several years, and then they'll just stop the cannabis completely, cold turkey, and they may do fine for a couple days, but usually on day 3 or 4, as their body has started to eliminate more and more of the cannabinoids through the urine and feces, they start to have withdrawals. So the best way to help somebody avoid withdrawals, which can be mild to severe, sometimes people can have diarrhea, insomnia, night sweats, vomiting, nausea, headaches, irritability. The best way to avoid that is also to help them titrate down slowly off their cannabinoid products. I've had some people who just stopped cold turkey without consulting with me first, and then of course they call because they're having these side effects. And so I do treat the withdrawals. I have them increase their cannabis dose a little bit or add some back in if they've gone cold turkey, and then start slowly reducing them again to avoid that withdrawal effect. I want to talk about pharmacogenetics a little bit too, because I think this is an area that we're going to see more research come out, and I'm hoping we do. As I mentioned, we do have some DNA companies out there that will test for pharmacogenetics to see how you metabolize different medications through those enzymes. There's definitely some cannabis companies that are getting into this area as well, where they're looking at your DNA to determine how you metabolize cannabis. It's, to my understanding, not any different from the current pharmacogenetic testing that we do, where they take a swab in your mouth and send that off. Some of the cannabis DNA companies will then provide you with a protocol that tells you how much to take and the different cannabinoids. You know, it's not really based on any clinical research at this point. You know, sometimes they'll say you take a ratio of 1:1, or you take a 5:1 CBD to THC, and you add these terpenes in, and it's all empirical data at this point. Clinicians can use the pharmacogenetics as data points for predicting the patient's response. I probably get 1% of my patients who have done a pharmacogenetic screening. These genetic variations can determine the strength of a dose, determined by how much of a cannabinoid is metabolized before the cannabinoid reaches the bloodstream, and by how much of that cannabinoid crosses the blood-brain barrier. The duration of the effect of a dose, determined by how efficiently your body can eliminate cannabinoids. I can also look at polymorphisms. So again, kind of going back to that earlier, the CYP2C9 enzyme has more than 50 polymorphisms, and the most common version is the number 1. With the CYP3A4, the 22 polymorphism affects THC and CBD metabolism. The COMT is a dopamine metabolizing enzyme that can determine side effects from cannabis use, and the P-glycoprotein drug transporter can determine the risk of cannabis dependence. So drug interactions, again, this is definitely an area where we could use more research. I personally use what's called LexiComp. It's an app on my phone. It will tell me when I look up a drug under potential interactions, it will list delta-9 THC and cannabidiol as potential interactions. And so it does give me a little bit of the ability to see if there's potential for an interaction here. We know that a drug can affect the metabolism of another drug, as I mentioned earlier. So by affecting a metabolizing enzyme, a drug can prolong or reduce the activity, intensify it, and side effects of a second drug. And this is really the only way right now that I can determine if someone's having a drug interaction, is to see if the side effects of that other drug are intensified, whether that's the cannabis or the pharmaceutical. The drug can impact how a second drug is absorbed and distributed into the body. So for example, there's some evidence that CBD has a stronger inhibitory impact on a particular cytochrome P450 enzyme if it's administered 20 minutes before the second drug. Often what I want my patients to do is to take their pharmaceuticals first and then eat something, and then they can take their cannabinoid products once they've finished a meal. That helps kind of avoid it. Early on, when we were concerned about drug-to-drug interactions, many of us cannabis clinicians were advising patients to avoid taking the cannabis within 2 hours of a pharmaceutical that could potentially have a drug interaction. I've since moved away from that recommendation, because what it was doing in some of my more complex patients is making it incredibly hard for them to comply, because they were on multiple medications multiple times a day, and it just became that they're almost like the only thing that they did was watch the clock to figure out when they could take these medications. So again, I just watch them to see if they're having a drug interaction. A good example is the warfarin, to see if their INR levels are going up, and to make adjustments based on that. Again, those INR levels may still stay within a therapeutic window, and we don't adjust the cannabis dose until it goes beyond that therapeutic window. When taken together, two drugs that are metabolized through similar biological pathways can produce an antagonistic or synergistic effect. So often I'll say to people that sometimes a drug-to-drug interaction isn't necessarily a bad thing. And we see this, for example, with our opioids. We know that patients who use opioids in cannabis can have a synergistic effect, and often they're able to reduce and sometimes even eliminate their opioid dosages when they start using cannabis. So that to me is a positive drug-to-drug interaction, because if we can get them off their opioids or reduce them, we can often also reduce many of their other medications. Sometimes their laxatives, because their constipation's improved. Sometimes we can get them off their sleep aids because now we've improved their sleep. So there's a lot of opportunities here for us to help reduce their polypharmacy. But as I mentioned, drug interactions with cannabis are rarely so dangerous as I have to discontinue the use of the cannabinoids. But they can certainly impact the other medications, and we just want to make sure that we're monitoring them. And sometimes, again, these impacts are positive. Prodrugs are an area where we still need a lot of research, and I think there's debate out there among cannabis clinicians with particularly some of the prodrug, the one prodrug, tamoxifen. We know that these drugs don't become functional until the body metabolizes them into a chemically different active component. So it's really important that they are metabolized through the liver and that there's nothing impeding their ability to metabolize. So cannabinoids, CYP inhibitors can slow down the metabolism of these drugs and allow the inactive compound to remain in the body. And this is definitely where tamoxifen has become a debate for women who use that drug post-treatment for breast cancer. We want to make sure that nothing is inhibiting the ability of tamoxifen to metabolize into that different active component. These are interactions that I have noted in my practice, and some of these interactions are positive and some are not so positive. We might see with benzodiazepines, muscle relaxers, hypnotics, anticholinergics, an increase in side effects like sedation, dry mouth, sometimes increased constipation with the anticholinergics, increased blurred vision. We might see increased CNS effects like dizziness and that sedation. Quetiapine, interestingly enough, I see with CBD sometimes it increases agitation in my Alzheimer's dementia patients. Dexamethasone, we might see an increased anti-inflammatory effect. With some of these antihyperintensives, sometimes we see where the blood pressure is actually lowered. So it's hard to say, is this a drug-to-drug interaction, or is this the endocannabinoid system restoring itself back to balance? So again, the takeaway message here is to really make sure that you're monitoring your patients for potential drug-to-drug interactions and adjusting their dosages as needed. Often, if I didn't prescribe these pharmaceuticals, I really try to work with the prescribing clinician so that we can get patients balanced on their pharmaceuticals and get them on the right amount of cannabinoids and make sure they're not having overall drug-to-drug interactions. Okay, that's it for this week. I hope you really enjoyed that little module there, and I look forward to seeing you next week.